All right, let's just jump right in. In today's explainer, we're going to completely demystify ascending cholangitis, looking at its pathology, diagnosis, and management. And we're doing it through the lens of a real-world clinical mystery. Picture this whole thing as a sort of animated medical sketch, where we draw out the absolute must-know facts, the current guidelines, and the gritty clinical realities of a disease that can literally turn fatal in just a matter of hours. By the end of this, you're going to have a crystal-clear framework for exactly how to identify and conquer this condition.
Here is our roadmap for the review. We'll start with our clinical mystery, move into the anatomy of the infection, how to spot the signs, dive into the diagnostic toolkit, talk about relieving the pressure, and finally, close the case. We'll throw in some handy mnemonics along the way, too.
Part 1. The Clinical Mystery. Let's look at a real scenario that shows just how sneaky this condition can be in the wild.
So, we normally associate gallbladder and bile duct issues with severe abdominal pain, right? I mean, it's the classic red flag we're all trained to look out for. But what happens if that classic symptom is just entirely missing? How on earth do you diagnose a ticking time bomb when the timer is totally silent? Consider this patient profile. We have an 82-year-old woman presenting with generalized weakness, a fever creeping up to almost 102 degrees, a racing heart rate of 113, and a really confused mental state. Her lab showed an elevated white blood cell count and a cholestatic liver injury pattern. But here's the kicker. She had almost no right upper quadrant pain. None. No clutching her belly, no guarding, just a very, very sick, confused elderly woman. Keep her in the back of your mind as we dig into the disease process. Part 2, Anatomy of an Infection. To figure out what's actually happening to our patient, we need to look under the hood at the underlying pathology and etiology. Simply put, ascending cholangitis is an infection of the biliary tract. Now, usually, the biliary tree is kept perfectly sterile by the constant flow of bile, those bacteriostatic bile salts, and mucosal immune defenses. It's a highly efficient system. But this infection gets triggered when something, most commonly a gallstone from cholelithiasis, or maybe a stricture, blocks that normal sterile flow.
Let's map out how this pressure cooker actually builds. First, we get a blockage. Because bile keeps being produced but suddenly has absolutely nowhere to go, the intraductal pressure spikes. Once that pressure exceeds 25 centimeters of water, those normally tight intestinal barriers start to fail. This extreme pressure literally forces enteric bacteria, like E. coli or Klebsiella, to translocate right across the barrier into the circulation. So what starts as a localized plumbing issue rapidly escalates into a massive systemic inflammatory response and outright sepsis. It's a pressure cooker waiting to burst.
Part 3, Spotting the Signs. How do we catch this in the clinic, and why did our 82-year-old patient throw us such a huge curveball? Okay, the absolute classic mnemonic you gotta know here is Charcot's triad. A really good way to remember this is the phrase, feel real jaundiced. Fever, right upper quadrant pain, and jaundice. Historically, ever since Charcot described it way back in 1877, this has been the gold standard framework for spotting ascending cholangitis. But here is the crucial point. Relying on this triad alone is super dangerous. Modern data shows us that a surprisingly low percentage of patients, we're talking only about 25%, actually show up with all three classic symptoms. Seriously, if you're waiting around to see the complete Charcot's triad, you are going to miss 75% of your cases. That's exactly why we almost missed it in our 82-year-old patient who didn't have any belly pain.
Now, if the infection progresses to toxic suppurative cholangitis, we hit Reynolds Pentad. Think of it as Charcot's plus AH. Hypotension and altered mental status. Basically, the patient's heart pressure drops and their awareness drops. That altered mental status, that was a massive clue for our elderly patient. You know, in older adults, delirium can completely overshadow any localized abdominal pain.
Part 4, the diagnostic toolkit. Since those classic triads often let us down, modern medicine leans on standardized frameworks to catch this stuff early. To make sure we don't miss these sneaky cases, we now rely heavily on the Tokyo Guidelines 2018, or TG18. To nail down a definitive diagnosis, you need one item from Category A, which is systemic inflammation, one from Category B, cholestasis, and one from Category C, imaging. You can make a suspected diagnosis with just an item from A, plus one from either B or C. By focusing on objective data, like a wonky white blood cell count or elevated LFTs, we don't have to sit around waiting for the patient to actually complain of pain. Here's a quick mnemonic note for your mental whiteboard. Recent research found a very specific inflammatory marker threshold. A C-reactive protein, or CRP level, of 10.3 milligrams per deciliter or higher is highly predictive of acute suppurative cholangitis. When you combine that with a high neutrophil lymphocyte ratio, it's incredibly good at discriminating toxic cholangitis from simple acute cholecystitis. So lock that number in, 10.3.
Basically, we're looking at a massive paradigm shift. We're moving from old-school medicine, where we relied purely on subjective clinical pain presentations, to new school medicine. We're now tracking objective lab data, CRP thresholds, and structured imaging pathways, like ultrasound followed by MRCP. We use these to speed up recognition whether the patient says their stomach hurts or not.
Part 5. Relieving the pressure. Once we've got our diagnosis, ascending cholangitis becomes an absolute race against the clock.
Just imagine looking at an endoscopic view of an obstructed, highly pressurized bile duct where you can literally see the purulent material, pus, just visible right there at the ampullary orifice. Seeing that thick, infected bile makes the abstract concept of toxic cholangitis viscerally real. And it totally explains why mortality exceeds 50% if that pressure isn't relieved fast.
And this is the gold standard management option in action, the ERCP. First, we are physically extracting the obstructing gallstone using a balloon catheter. Then, a biliary stent is placed to keep the whole pathway open, which allows all that trapped, infected pus to just drain spontaneously. Mechanical decompression really is the primary cure here.
Now, while mechanical drainage is absolutely the critical fix, you have to pair it with pharmacology. For severe septic cases, empirical broad-spectrum antibiotics need to be rolling within 1 hour. For milder cases, you have up to 6 hours. Once you've got source control via ERCP, the Tokyo guidelines recommend continuing those tailored antibiotics for exactly 4 to 7 days. You'd really only extend that therapy to a full 2 weeks if you find gram-positive bacteria, like Enterococcus or Streptococcus in the blood, just because of the risk of endocarditis.
Part 6. Case closed. Let's tie this whole explainer together and see how our clinical mystery actually concludes. So, what happened to our 82-year-old patient? Well, because her medical team completely ignored the absence of abdominal pain and instead focused on the objective labs, the cholestasis, and her altered mental status, they used the Tokyo guidelines to make a really rapid diagnosis. They started early antibiotics, performed a prompt ERCP, drained that purulent bile, and got the stone out. She eventually had definitive gallbladder surgery and recovered beautifully.
The ultimate takeaway from this explainer is that recognizing atypical presentations and acting fast with source decompression literally saves lives. Biliary pressure demands immediate relief. If you found this animated sketch-style explainer helpful, please hit that like button, share it with your colleagues, and subscribe so we can keep bringing you these high-yield medical reviews. I'll leave you with this final thought. The next time an elderly patient rolls in confused and feverish but completely denies having any abdominal pain, are you going to catch that biliary pressure cooker before it bursts? Thanks for hanging out with me, and keep learning.